these areas and in other topics, of course, in the future. So let me see if I can make sure that my actual screen is advancing. There we are. So the outline for today really is we're gonna mostly speak about single units or small, restoration, both posterior and anterior. We're gonna couple the digital workflow whenever we can, especially from an efficiency standpoint, and I'll let you know what we have done, of course, for a number of years. But then as we move into more the immediate implants, the anterior area, of course, the soft tissue, the aesthetics will really come into play. And we'll discuss, how we can maximize and optimize, of course, those important factors for our restoration. In this, of course, there is a fair amount of biology involved in terms of tissue thickness and keratinized tissue. And, we're going to touch base less on implant removal and then the management of complication, obviously because of a reason of time. We have about 90 minutes today. So if we start with a simple restoration, like the posterior one, like you can see here, this, lower right first molar. This is a crown supported by an implant, but, the first observation will look like a crown that's present on a tooth or a natural tooth. So we can say that we've done actually quite, a good job. Of course, in the posterior area, you don't really need to be a rocket scientist in order to place an implant in the right position. If you have a single missing tooth, ideally you need to draw two diagonal, and I'm going to try to see if I can perhaps show you with my mouse. Hopefully you can see it. One diagonal from here to here and one from here to here, and effectively there is your implant osteotomy. So in those areas, it's really straightforward, both from a mesodistal and a buccolingual standpoint. Same thing from the premolar side. Those are sites actually that should be almost the first one where somebody is getting close or is starting the initial experience with dental implants, because in these areas there are no anatomic or nerve component that, of course, need to be avoided. And the aesthetics, although can be challenging at times, is not exactly like a central incisor. So those are ideal sites really to start placing an implant. And again, they lend themselves extremely well to the placement of an immediate implant, which is the topic, of course, of today. So it becomes a little different, however, when we look at this restoration. Now we're thinking, well, where do we place them from an apicocoronal standpoint? Of course, we don't want to place them too deep, but at the same time, we'll see often, we don't want to place them too shallow because there's a number of drawbacks that will really come with it. So if we look at posterior implants, there are three things, among others, of course, that come to mind. One is the availability of interocclusal space. You need to have the place for the crown. I know it sounds redundant. It sounds like obvious, but you'll be surprised how many times implants go in place and there has been no plan, no thought as far as how much space do you need for the actual prosthesis. Let's remember, people don't come for implant, people come from teeth. Then we need to look at the emergence profile, which is, of course, important, although from an aesthetic standpoint, it is important for the establishment of what we call biologic width. So if you look at the obvious here, there are three implants being placed a number of years ago. And as you can see, the one on the second molar, effectively, there is almost no space. There is a space only for a restorative component. So if you can't place something, if you can't place a component there to make a tooth, then of course it becomes really irrelevant if you actually have placed the implant. And when you look at this type of restoration, you see here that there was a screw retain restoration. We did place a crown there, but we have no space to actually put any kind of filling on top of that screw. So the screw is exposed all the time. Although it's not the end of the world, certainly, it's not an ideal planning. And again, planning is everything, of course, in these situations. If you look at this situation, this is a real case that I just finished just recently. This is a CT scan, and you can see that two implants in the areas of, if you use the international system, 46 and 47, had actually been placed already. And however, there was no thought process about the interocclusal space. The interocclusal space available in this specific case is about 2 millimeter, 3 millimeter at the most. So again, you do not have the space for the restoration. So there is only one choice for those implants. Those implants have to be removed. Inadequate osteotomy has to be done in order to recreate the interocclusal space for the crown. And of course, new implants placed, as you see planned here in this computer software. The next phase, of course, is the emergence profile. As we said, it's not truly critical in a posterior restoration, but it is important for the establishment of the biologic width. Now here, let's have a little moment of pause. So if we look at those two implants that are placed in the respectively 36 and 46 area, one might think that they are okay. But if one trying to project where the gingival margin of those molars will go, you realize immediately that those implants have been placed without due consideration for the placement of the crown. So therefore, if the implant is at that level, there is no other way of making that crown than to make them look like a mushroom, like you can see here, which of course become virtually impossible to clean. And of course, while we know that implants don't get caries, we still need to make sure that there is adequate space and adequate emergence profile in order to carry out oral edging procedures. And then, of course, it is no surprise that a number of years later, you start seeing this remodeling coupled perhaps with some periimplantitis problem that really create a significant amount of bone loss. So again, you might think, well, that's a mandibular molar, really doesn't make a difference. But it's actually more common in the maxilla. So if you look at the edentulous, like when you see it right here, and you're thinking about placing some implants in that right maxillary area, in the right mandibular area, one might look at a CT scan and say, well, we have plenty of bone in that area. Here is our planning. We're going to place those implants where the bone is. But realistically, that is not really where the implants should go. Because once again, if you're trying to project where the gingival margin is going to go, and we know that those implants have to go about 3 millimeter below the buccal gingival margin, we immediately see that there is too much bone, and placing those implants at the level of the crest will inevitably bring them too close and too shallow. So too close to the gingival margin and too shallow. So therefore, it will be realistically impossible to restore them with adequate aesthetics. So again, this, of course, can be done with a mock-up, with a setup, or a wax-up of some sort. But again, even just a simple projection, as you see here, done digitally, where the gingival margin is projected to be, really comes quite helpful. So if we look at this situation, really we need to project where the gingival margin is going to go, irrespective of where the bone is. And in fact, we'll see later on when we discuss, especially about congenitally missing lateral, that we need to reshape some of those areas in such a way that the gingival margin position is actually anticipated. So here is the biologic component, the biologic width. And if you look at any implant of any type, this is actually a part of the soft tissue which is fairly constant, fairly stable, contrary to what we find around natural teeth. So the biologic width around an implant is roughly about 3.7 millimeter, where half of that distance is occupied by your epithelium, and half of that distance is basically connective tissue, though not inserted, of course, around the implant. This has really been ascertained in a number of studies, especially by the group of Berglund, and in this case by one of my Italian compatriot, Cristiano Tomasi, in 2014. This was a human study, actually, not an animal study. So if we look now, instead of the thickness of the soft tissue that we have, and this is just in the posterior area, you can see that very often that tissue is actually not thicker than 2 millimeter. So you start wondering if my biologic width, my cuff of soft tissue around that implant will be formed and will have roughly a 3.7 to 4 millimeter thickness, how is that tissue now that's only 2 millimeter thick going to react? What is going to make that type of biologic width possible. And realistically, if you look at this, it is a combination between some soft tissue in the thickness that you have it and a potential resorption of the crestal bone that you might have. By the way, these measures of 2 millimeters roughly are very common in many other areas of the mouth. In fact, we're currently doing a study to map in a fully edentulous patient the thickness of the soft tissue in a number of individuals. We have a clinical study that's best come to conclusion. So we need to think biologically. We can't just think mechanically. And when I say think biologically, is that you need to anticipate, again, the formation of the biologic width. So if you only have 2 millimeters available, it's either you thicken the soft tissue, you make it thicker to about 4 millimeters with some form of grafting, or you may need to place that implant slightly subcrestal in order to anticipate, again, that crestal bone loss that will, and I say will surely occur as the biologic width forms. So again, here is just one type of strategy. If we have a 4/6 that's missing and we're going to place an implant, and you can see right on the buccal, the typical thickness, the typical lack also of keratinized tissue. Well, here is a material that's a xenograft, but it's a soft tissue grafting material that can be basically placed around that implant with the purpose of trying to thicken actually that soft tissue. So if you look at the same case as before, and this is, of course, is after your implants is placed. And you can see that, again, that tissue has been significantly improved. Now, when we do this type of restoration in the posterior area, we need to wonder, of course, not only is the final result, which of course will be our crown, but how fast and how efficiently we can get to that result. So often, you might select a multi-step procedure, one in which you might extract the tooth, perhaps place the implant at the same time as an immediate implant. I will go through in a minute. Or you may even let the area heal, perhaps with bone grafting, and then go back and place your implant. Then you go back another time, and after healing, and you take your impression, either an analog or a digital impression. And then, of course, you go back and you place a crown. So anywhere from 3 to 4 appointments. So the question now is, can you decrease the number of visits so that you can be more efficient? And does that perhaps bring any kind of detriment, any negative side effect? So we often use, actually we have used probably for the past 10 years, what we call an immediate scanning protocol during immediate placement, meaning that we're going to extract the tooth, place the implant, and scan, take that impression, often digital, although we have done it also with an analog fashion. But we take a digital impression at the same time that the implant is placed. So our next appointment is effectively crown delivery after osseointegration has been achieved. So if you schematically represent the number of appointments that you will need, realistically, you only need those that are marked in blue. You have a surgery, you take a digital impression, and you're going to see basically the patient just basically for seating your restoration. You'll see here it says restoration seating with papillary incision. Now, why do I say that? Because, of course, these are all crowns that have been designed, and delivered that way. By the way, regardless of the type of scanner that one might use, they all work extremely well for this type of application. But realistically, if you look at the picture on the left, and you know that soft tissue has been shaped by the presence of a healing abutment. And generally, a healing abutment, especially in the posterior area, does not have the same diameter as a molar in this case. So as you go to sit your molar, it is often typical that the soft tissue now it's impinging. Actually, the crown is impinging on the soft tissue, I should say, and actually it becomes very hard to seat. I've seen many times, dentists, including some of our residents, trying to mold the shape of the tissue with a temporary restoration. In this area, really in the posterior area, there is no need to do so. It is very simple, very easy. Just to make a very simple incision, as you can see here in the papilla, in the posterior area, and slightly move that tissue. But moving that, basically making that incision in the interproximal area, breaks down the cuff of fiber in that soft tissue, so that as you seat your crown, your crown will basically extend, and stretch that tissue without any problem. And often there isn't even need to put any sutures around those two little papilla that have been just, pulled apart. Again, you can see the same in the mandible right here, where again, if you go from the left to the right, the left is soft tissue as shaped by a healing abutment. Very simple incision in the papillary area, and you can sit your abutment. In this case, is a cement retained crown. But if it was, of course, a screw retained crown, it can be the entire crown abutment assembly being seated at the same time. And again, here heals extremely rapidly and well, and more often than not, there is no need to suture those papillas back again. So if you look at an immediate placement in the posterior area, one may wonder, what are the challenges? And of course, the challenges are mostly related to implant stability. We have a large socket. We need to place an implant, and we need to make sure that we achieve primary stability. So how do we do that? The question now becomes, do we have enough bone to actually stabilize that implant? And there are a number of classifications, including this by Smith from New York City, where if you do have enough interseptal bone, you might stabilize an implant, let's say a normal standard size implant, 4, perhaps 5 millimeter diameter. But the problem becomes when you do not have that septum and the ability to stabilize the implant in that area, which is actually more often than not. So you need to resort to some different type of implants, like a larger diameter implant. So here is an implant. It happens to be a Straumann implant, but it's about 4.8 millimeter in diameter, which was placed right in the septal area. Now, when you do place an implant there, especially at the beginning of your career, it is somehow challenging because the implant tends to fall either onto the distal root or into the mesial root space. So it becomes a little hard to make sure that you can stabilize that implant from the buccal and the lingual remnants of that septum. Of course, this case was possible. So again, we went ahead and placed a crown, but that would not be the first, let's say, the first type of implant that I would suggest somebody to place when you start placing immediate implant in the posterior area. So then the question is, how do we stabilize the implant? Can you stabilize it apical to the tooth? Is there enough bone to place that implant and stabilize it at the expense of some bone apical to the socket? Well, we need to go back, of course, to anatomy, both in the maxilla and the mandible. So if we look here at the distance between the apex of the root of the mandibular posterior teeth and the inferior alveolar canal, what we notice is that distance is anywhere between 3 and 4 millimeters. Now, we know from a safety standpoint that we should be at roughly 2 millimeters away, of course, from the inferior alveolar canal. So realistically, that tells us if the distance is only 3 to 4 and we need to be away 2, realistically, there is no bone that you can use apical to a mandibular molar, let's say. What about in the maxilla? Well, is there enough bone apical to a maxillary molar? Only in about 25% of the time, as you can see on your photo on the left side. But in the great majority of the time, 3/4 of the time, your sinus either comes close to the root or actually invaginates within the roots. So basically, it does not allow you at all to have any bone that's present apical to the tooth. So what can we do then? If the challenge is to ensure the primary stability, is there any other way that perhaps we wouldn't consider in the anterior area, but that we can consider in the posterior areas? So the question is, if you can't stabilize the implant apically, what about laterally within the socket? And again, this is something that as we will go towards the anterior implant, we will see it is a huge no-no. We will never in an anterior area utilize the buccal, especially the bone, especially on the buccal side, to stabilize the implant. But what about if the posterior area might be different? And if you look at this data, this describes the mean buccal and lingual wall thickness of the bone in a posterior molar site. So what you see is that now the thickness of that bone, which is in the anterior, is often about 0.5 millimeter, It's here anywhere between 1.5 to 2.5 millimeters, so much, much thicker. So there is a potential here to stabilize an implant within the lateral walls of the socket. And of course, as you move further apically in those sockets, you know that that thickness further increases. So again, it will make us more comfortable to make sure that, again, those implants can actually be stabilized. But of course, when you do that, you can't just place an implant that's 4 or 5 millimeters in diameter, because the socket is actually wider in both buccolingual and mesiodistal direction. So you have to think about some larger implants, some 6, 7, or 8 millimeter implant, which of course are present on the market. We often use either this BioHorizon or the Straumann implant, but again, in your continent, Southern Implant, based out of South Africa, makes this wonderful implant that can actually fill the socket and can achieve exactly the same type of result. So now if you think from an example standpoint, this mandibular molar, this molar is actually fractured on the lingual side. So we're going to take out that tooth. And again, you can see how thin the buccal, the interseptal bone is. We're going to use a program, a specified sets of drills. And as you see here, there is a final drill that, it matches the size, both in terms of width and in terms of length of the implant that you're going to place. This is in the BioHorizons system. Now, you might wonder what that, Harley Davidson engine does, what is the meaning of that engine? And the reason why I brought it there, just to bring a little humor, because one day when I was doing one of the surgery with this large implant in a colleague of mine, this large drill produced a fair amount of vibration, a fair amount of chatter. And I was feeling kind of guilty. So I was apologizing to my patient, and his answer was, it is no different than riding my Harley, because I guess there are similar type of vibration. So again, that's the reason why I put the engine there. But again, if you look at this implant, again, this is one of the immediate molar from BioHorizon. You can clearly see that, again, the 7 millimeter implant in this case was able to achieve primary stability by engaging the buccal and lingual wall of the socket. So then, what are the do's and don'ts in the posterior side in terms of immediate implant? You always want to keep the implants in the middle of the socket and use a molar type of implant so that you can achieve your primary stability. You want to engage the apical lateral walls of the socket for primary stability. Again, more often than not will be the lateral walls, and very rarely will be actually a component of apical bone. You never, at least try, raise a flap. There is no need for it, especially if you have cross-sectional imaging, because you want to maintain the soft tissue vascularity that's provided actually to the bone as well. You need to graft the residual site, meaning there is going to be a gap between the implant and the socket, and that area should really be grafted, especially more critical in the anterior area, but I think also should be done in the posterior area. And then, as we said, you want to take a digital impression at the time of surgery. That implant is not going to move. So effectively, its relative position related to the teeth will be exactly the same. And remember what we said before, if you're wondering about, well, what about the soft tissue emergence profile? Remember what we discussed about doing those mesiodistal incisions, okay? So again, the implant goes in place. You can see, right here is in the right position. This is an old scan with a scanner from 3M. Today we use mostly Trios and other types of scanner. But effectively, here is your end of your surgery. There is some bone graft. There is some interrupted sutures, and the patient is ready to go. Comes back about 2.5 to 3 months later, once osseointegration is achieved. You remove your healing abutment, soft tissue ideal, and you just basically go on ahead, you're going to sit the crown. Now, in this large implant, given the size also of the healing abutment, there is generally even no need to actually perform the mesiodistal incision, because there is a greater correspondence between the size of the implant and the size of the molar that actually you're going to place. So again, if you're looking at the protocol, The protocol is that you're going to take the tooth out, like you can see in that 2-4 tooth. You're going to place the implant, graft that area, you're going to scan, and you come back about 2.5 months later to actually make the impression. Again, the premolar sites, the must-do is exactly the same as for the molar, nothing different. Okay, so I'm not going to repeat that part. Perhaps the only difference is the fact that in the premolar site, especially in the maxilla, you do have enough bone apical to the socket so that you do not have to engage perhaps the buccal component of the bone. Because again, as you move anterior, the thickness of that buccal bone is going to decrease. And if you attach or if you place the implant close to the buccal bone, you're likely going to have a recession and, of course, an anesthetic result. Now, what about the emergence profile here? Well, the emergence profile is going to be designed like you will design a tooth at the level of the gingiva. So you're going to ask the laboratory to disregard the shape of the soft tissue as you have it in your digital impression and just design the crown exactly as a tooth would be designed at that particular cross-sectional area. Now, what I've been telling you is that you can couple all of this, factors together. And of course, is, the question you might have is, yeah, you said so, but does it really make a difference? Is there any downside from a, let's say, peri-implant condition, bone levels, or is it perhaps characterized by aesthetics of the soft tissue that are inferior to a normal, more conventional protocol? So a number of years ago, we started first experimenting with a case series, as you can see here. And then actually we went through with a cross-sectional studies where we first look at two-part study, where we first look at not only the crestal bone level, but also all the peri-implant parameters, probing depth, bleeding or probing, and a number of other things. And if you look at this from a health standpoint, from a bone level standpoint, there is basically no difference when you compare crowns that have been restored with this immediate scanning protocol versus crowns that have been fabricated, after the soft tissue healed by taking an impression, of course, at that time. So the two techniques are exactly the same, but again, one is much more efficient and certainly shortens the treatment time that you have with your patients. If you're wondering from a soft tissue and aesthetic standpoint, we also look at the pink aesthetic score. Now, the pink aesthetic score is just an index that basically characterizes the presence or absence of papilla, the presence or absence of adequate soft tissue buccal to the crown, texture, and so on and so forth. So basically it defines the ideal soft tissue contour that a tooth should have. Again, when you look at a comparison between teeth that have been restored with these immediate scanning protocol versus crowns that have been fabricated after the implant tissue have healed, there is really no difference. And actually, there is a tendency for the immediate scanning protocol to produce better soft tissue, similar to what you will have around a crown that has been immediately restored at the time of implant placement. And again, I'll get to it in a minute. So, having said that, we have so far discussed about posterior implant and ways to maximize the efficiency and the stability of those implants. But what about anterior implants? So in this area, of course, the position of the implant is even more important, because if you can perhaps make up for a mistake in the posterior area and just go along with it, a mistake in the position of the implant in this anterior area will certainly be corresponding to a much more negative result. So the pictures that you see here describes what we call a zone of safety versus zone of danger. Of course, the safety is green and the danger is red. From a mesiodistal standpoint, the picture on the left, also you see it also from a buccolingual standpoint, where the implant should always be positioned towards the palatal side of the bone and never, absolutely never, procline towards the buccal side, either of an extraction socket or incline, if placed in a hyoidodentous ridge, towards the buccal. And then, of course, there has to be an apicocoronal standpoint where, as we said before, we need to anticipate where the gingival margin of the final tooth will be, and the implant will have to go about 3 millimeter apical to that area. So in this case, it's not the specific planning. There are many ways to certainly get to the same result. It's not the specific planning that's important, but it's actually the planning itself, the fact that we sit down and we're trying to anticipate what we have. Because if you have situations like this, where you have a high smile line and you can clearly see an implant that has been placed way too apical and way too buccal, this in the United States, we call it a lawsuit waiting to happen. There is really no way that you can actually recreate a ideal contour after this implant has been removed. Or you may see implants like this that were down on the buccal, too coronal and too buccal, and certainly will provide really a hard time, not only for us to rematch now the soft tissue that we need to add to the crown, but also from a component standpoint, becomes much, much harder. So I make a joke here, say, those crowns look good in terms of what the patient thinks. The patient is very happy. But again, the amount of hassle that we have to go through certainly justify my little cartoon on the right side. What about this one? Again, we're not going to go in the detail of how we fix this one. Perhaps we'll expand in a future lecture. But you can see that this implant being too wide and too buccally placed has created certainly a lack of both the quality and the quantity of the soft tissue that should be surrounding the restoration. So that implant is certainly not healthy and is certainly not aesthetic. So anytime that we look at the position of the implant, especially in the anterior area, it's always helpful to look at perhaps classifying situation in which we feel comfortable. Perhaps at the beginning of our career, when we first start learning about implants, versus situations that are a little harder. So we need to differentiate the proverbial walk in the park, like you can see on the left side, to something that requires a little more caution, a little more attention to the detail, to perhaps something like you can see on the right side that really should be left to very experienced individual. So having the ability to actually differentiate between these three scenarios is extremely important, not only for our patient, but of course, for us as well as practitioner. And if you look at this classification from the International Team of Implantologists, which I'm proud to be a fellow, there are a number of things that really you can look at. But realistically, the most important one you should be looking at is the characteristics of the smile. Is the patient a low smile, like I am? And it's about 20% of individuals have the smile that you see on the left side. But about 60 to 70% of individuals have the smile that you see in the middle, where now not only a patient will show the tooth, but will also show the characteristics of the papilla. And then there is about a 10 or a 20% of the population which really has a high smile line and shows completely the interface of the transition area between the soft tissue and the crown. And of course, those are the most difficult patients, of course, to deal with in terms of aesthetics. So, I joke sometimes, I say, rather than may the force be with you, in this case, it's may the low lip be with you, because you need to immediately look at the height of the smile as one of the most important criteria to understand if you want to treat that patient or not. Now, this is my very personal classification system. And you start from the top where you basically have everything that's going for you. Biology really has created the soft tissue, the hard tissue, everything's in the right place. So I call it do not harm or mess up. Then there is the one where you really, again, have almost everything going for you. You just need to plan right and preserve what nature has given you. And then as you move down, of course, there are situations where that transition between the teeth and the soft tissue is progressively in a worse shape. And now you need to rebuild it, either with some manipulation of the soft tissue or eventually some hard tissue augmentation. All the way through the cheating. And when I say cheating here is meant in a good way. It's not meant in an unethical way, meaning recreating perhaps prosthetically some of the soft tissue with some pink colored materials. So the soft tissue is really the area where the majority of mistakes will actually be done. So all the crowns here, in all these three photos, one of the incisor is actually an implant. But in the left side, you have a hard time thinking that 1-1, it's actually an implant. In the photo in the middle, again, 1-1 is again the implant, and you perhaps can see that because there is a little bit of a recession around that tooth. And on the picture on the right, of course, you don't need to be really a rocket scientist in order to figure out where the implant really is, because of course it's a tremendous failure. So the idea is that you need to plan, and preserve what you have. So in doing so, perhaps one of the most important series of paper were the one done by Dennis Turnow at NYU, and now, of course, at Columbia, where he looked at the relationship between the interproximal point, the most apical part of the interproximal point between two teeth or an implant and a tooth, and the most coronal area of the interproximal bone. What he noticed is that if you're looking at this distance here, if the distance, it is 5 millimeter or less, meaning from here to your bone up here, which I might just make up here in this case, if that is the outline of the bone, and the distance from this crest of bone to here is 5 millimeter or less, your chances of having the papilla, the number of times the papilla is going to be in place, is virtually 100%. So having said that, if your soft tissue are in the right place, your implant is placed 3 millimeter below the gingival margin on the buccal, you may expect, again, that distance to be fully filled by soft tissue. Now here, what is important is the interproximal bone and the contact point. So both of them are important. You need to have both. You can't just have one of them. And let me show you actually this case. This is a case of mine a number of years ago, about 15 years ago. That patient is going to lose that number 2-1, and the tooth will be replaced with the metal ceramic crown, as you can see here. Now you notice there is a lack of papilla in that area, although everything else seems to be in good shape. And as the patient, had that crown, of course, he noticed immediately that soft tissue, and he asked me what I was going to do with it. Well, I said, listen, don't worry about it, because if you leave it there long enough, generally about 6 months to a year, there is often the ability of the soft tissue to actually grow down a little bit and make sure that it fills that area. So the patient then came back at about 10 years. Once he comes back at 10 years, you can clearly see that the restoration looks great, but the papilla really hasn't grown that much. So here is where, the difference between a mean result in a study and what is called the two extremes become important. Because it is true that as you deliver a crown, there is a tendency of that papilla to grow by about 1 millimeter. But again, this happens as a mean. And often, we end up treating patients that might not be really fitting within those mean results, but they may be on the extremes. So often, again, these situations might not be correct. And if you look at a radiograph, as I've done here, you can clearly see that in this area here on the mesial, the bone is certainly a little more apical than it is on the distal side. But again, that papilla here on the distal side is certainly more supported. So although this may appear as very minute differences that perhaps shouldn't be noticed by the patient, it really depends on the patient and often the area, how demanding these patients are, of course. So we all know that they come in different shapes. So what is important is the interproximal bone, as I said, and the contact point, and not just one of them. So if you look at this patient with the diastema, for example, and that tooth 1-1 will be removed, we did a stage approach. You see there is a nice thick biotype. We're going to then place an implant and place a temporary crown, and we're going to start molding that tissue. In the anterior area, we take advantage of using a provisional crown in order to start shaping the tissue for obvious reason of aesthetics. But now, as you take that crown off and you say, well, do I have a chance to perhaps mold that tissue, push it a little bit towards the mesial so that it will go further down and fill in a little more the interproximal space? And the answer is really no, because you do not have that contact point. You might have the bone, but you do not have the contact point. And again, here you see the patient try to ask me to make a little wider crown, but certainly was not the way to go. By the way, you might not notice this, but I want to just make sure that for those of you that might be more computer aware, this crown has actually been altered with Photoshop, okay, in terms of the color. So I want to tell you, because sometimes, especially today, not everything you see might be actually true or as completely true. So you always need to have a skeptical eye. Often when you see something that's too good to be true, potentially it is, okay? So just be careful. So what about the position from an apicocoronal standpoint? Well, we said that the magic rule states that we need to be 3 millimeters below the gingival margin on the buccal side. So again, we project that buccal margin, or we design it with a setup or a wax up of sort, and the implant will go 3 millimeters at least below that buccal gingival margin. And here again, what is important is the emergence profile, and once again, the biologic width. So if you look at this case, tooth 1-1 is actually an implant. But if you notice, there is an ideal placement of that implant in terms of the apical coronal component. Now, if you look at this, of course, we've seen that before. This is way too apical, which sometimes does occur. But the other mistake is also possible. Look at these 4 implants. I did not do these 4 implants, but I will think that the dentist that places 4 implants actually places them all within bone. So before placing the crown, chances are that that bone was fully covering those implants. It's just that there was no plan in terms of where the gingival margin of the teeth will be located. And if you notice, this crown really looked like total mushrooms. Not only they are impossible to clean, but again, will cause the resorption of that crestal bone as a function of the formation of the biologic width, which we said it's about 4 millimeters. So whenever you place an implant, the so-called bone level implant, you really do not want to place it just at the level of the bone. Because the moment you lay a flap, you're going to lose a little bone. So actually, this is a clinical study that we did a number of years ago. But really, the take-home message that you want to have is that you should be placing that implant about 1 millimeter to 1.5 millimeters subcrestally. So not at the crest of the bone, but actually subcrestally. Because in this case, you will compensate for a little bit of bone loss as a result of your surgery. You will allow for the biologic width formation. Remember, we said generally those tissue, more often than not, it's only 2.5 millimeters thick. So if we need to anticipate the biologic width of about 4 millimeters, we perhaps need to place the implant a little deeper. And plus, you may have a little more space to design your emergence profile. Again, if you look at this schematically, and this is a case of one of my former graduates, Dr. Cortez, there are central incisors which will be removed because of internal and external resorption. But also there are deciduous canines, as you can see them here. So again, in this case, Dr. Cortez is trying to anticipate with the black line where the gingival margin of the canine will actually be located. And then, of course, if he projects 3 millimeters apical to that area, that's where the implant should really go. However, as is often the case with congenitally missing teeth, once you open that flap, you always find that that bone is located too coronally. So if you lose sight of the ideal implant position, you're going to place that implant way too coronal. Realistically, what you need to do, again, is you need to project where the scalloping of that bone should be or should have been in case you actually had a tooth in place in that area, I mean, a permanent tooth. It is no different in a congenitally missing lateral, where you can see, especially here, that the outline of this bone is perfectly horizontal. So if you're trying to design or plan in these situations, where that implant should go. Should it go at the level of the bone, or should it go slightly subcrestal, again, to compensate for that scalloping that is not present? You know already that the left side is really the way to go, not the right side of your screen. So again, let's look at this surgically. If this is your flap immediately open, you can see that your natural teeth have a scalloping, but that area of the lateral does not have a scalloping. So what you really ought to think about it before you start your osteotomy for your implant is to recreate the natural scalloping of the instruction socket. And only after you're done that, okay, you are going to then start the drilling for your implant. So first, you recreate your normal bone scalloping. You can do it with a high-speed MPs and a large, round burr, or you can do it with any other instruments that you feel appropriate. And then, of course, you initiate your osteotomy according to the implant system that you use. Again, here is the implant going in place after the osteotomy is being completed. And again, of course, in this situation, we often have to manage limited mesiodistal space. So then, once you've done that and you scallop that tissue, then the soft tissue will just basically heal around your restoration once it is placed, like you can see here, nice. Or you can see in this situation, this is at the time of delivery, as you can see from the little ischemia, the little blanching around the tissue. But again, if your scalloping was done correctly, then the anatomy of the crown will actually shape how the tissue, the soft tissue, is going to actually look. Now, what about buccolingually? We said that the last thing that we want to do in any situation, but especially in an immediate implant, is actually to place the implant towards the buccal bone or touching the buccal bone. We must be towards the palatal bone. Again, this is no different if you have an immediate implant, like you have on the left side, where again, you're placing the implants towards the palatal component, and then we will see later, we're going to graft with some slow resorbing, generally xenograft bone, that gap between the implant and the remaining part of the socket. But it is also true if you have a heel edentulous crest. You do not want to place that implant too close to the buccal bone or procline in such a way that you will have then a wrong emergence profile. So realistically, what I tell my students is really doesn't matter if you're dealing with an implant that is immediate or non-immediate. Because in non-immediate implant, in a heel edentulous crest, you likely need to rebuild, okay, some of the hard and soft tissue that has been lost as a result of ridge resorption after the extraction. In immediate implants, you might need to over-augment a little bit, perhaps the hard and the soft tissue, to compensate for some of the shrinkage, for some of the ridge resorption that will occur actually later. So again, the job is the same. It's just the timing, the temporal sequence of that ridge resorption that is different. So again, if you look at immediate implants, doesn't matter if you do one or you do a number, you need to place them within the palatal component of bone, and you're going to graft the area that's present on the buccal. Here again is just a 3 immediate implant, as we will see in a few minutes. And when I speak about immediate implants, I want to really pay tribute to one of my dearest friends, Dr. Isaac Barzilay, and the graduates of one of our program back in the mid-'80s. Dr. Barzilay was actually the very first individual who did some animal studies in monkeys over the feasibility of actually placing implants in extraction socket. He was the very first individual who actually showed this and then published a number of years later. What would you do immediate implants? What are the advantages and disadvantages? And you can look at them from a patient standpoint, from a practice manager standpoint, and of course, from an outcome standpoint. So from a patient standpoint, I'm assuming it's everywhere is the same around the world. But if I look at my children or anybody, there is a sense of immediacy. People don't want to wait for a result. If you ask them to wait weeks or a month, they want to say, I want to do it now. And so if there are ways to, of course, satisfy that sense of immediacy and gratification, I think that certainly will bring additional patients, of course, happiness. We're all dealing with internet and the ability of patients to actually comment on their experiences, not only at restaurants or venues, but also at the dentist and at the doctor's office. So that ability to post reviews that are actually positive, that share their experience with other individuals, is certainly important for our practices. From an efficiency standpoint for us, well, time is money, let's face it. So if you have a more efficient way of delivering the same treatment, all other things being equal, that certainly should be preferred. And then, of course, if you look at the characteristics of the outcome, meaning what is the predictability, the aesthetics of the soft tissue especially, but perhaps also the hard tissue, this is the part that we need to be really sharing. Well, forgive me for a second. Christian, can you close the door upstairs? Yeah, guys, I'm in my house, so the door of, I'm in my basement, so the door of my basement was actually open, so you can actually hear everything. My apology. So if we look at immediate placement, what are the challenges that we have? Of course, implant stability is one. The predictability is certainly important as well. But most important is really the aesthetics, the soft tissue that we're going to achieve. So how are we going to support that soft tissue architecture? And realistically, it's going to be with the help of either a custom healing abutment or an immediate temporary crown that we place at the time of implant placement. Because the idea is that we do not want to have that ideal soft tissue after the extraction of the tooth to be altered by the placement of a healing abutment. So what are the do's and don'ts for anterior implant, immediate implant? Well, in this case, it is fundamentally important to keep that implant palatal. You want to engage the palatal component for your primary stability, the palatal component of the socket, and never, ever engage your buccal plate. If you do, that is basically the kiss of death. You will have a recession of that area, no matter which implants you use, no matter what you do. You never want to raise a flap, especially on the buccal, because that bone is already thin. And that bone is realistically only vascularized by the periodontal ligament, which now you have removed because you have removed the tooth, and by the overlying soft tissue. So that soft tissue should remain attached to that thin buccal bone in such a way that it will be supported. You want to graft a residual socket with a xenograft or a slow resorbing material in such a way that you're trying to minimize the changes of that socket. And you want to place an immediate temporary crown if you have the primary stability. Or if you do not have the primary stability, you want to create some form of customized healing abutment. So again, let's look at a case. I'm going to look at a bunch of cases, but the implants again is placed towards the buccal side, towards the palatal side, my apology, of the socket. We're going to place a temporary crown. We're going to graft it. We're going to let the soft tissue heal around that ideally shaped temporary crown. About 3 months later, we go back, take our impression. We take the impression not only of the implant position, but also of the soft tissue. We fabricate the final crown. If your implant does not have enough of a primary stability, and you don't feel comfortable placing an immediate temporary crown, you either place an immediate healing abutment that is customized to the shape of the soft tissue, or you may place a pontic, like you can see here. This is just a fiber-reinforced bridge with a pontic that goes right in the socket, okay, and basically supports that ideal emergence profile so that the teeth now will heal. So the soft tissue will heal around that pontic. We just need to go back then and finish your restoration. In this case, that is a zirconia customized healing abutment. And then we have 3 porcelain veneer that have been made. And this again is the final restoration that you have seen already before. Again, this is your cross-sectional imaging of the implant, and you can see that you can rest assured that that area, the buccal bone, will actually be in good shape, because if you look at the thickness that we've been able to achieve after a number of years, you know that that buccal bone will actually remain stable. Let's look at other cases. That tooth 1-1 is fractured vertically. It will have to be extracted, and we'll also make a crown on tooth 2-1. So we do an atraumatic extraction to the extent possible. We just make a very simple intrasulcular incision, and we don't use any kind of peritome. We just basically luxate the tooth and remove it to make sure that we maintain the integrity of that socket. Once the implant is placed, then it's a matter of fabricating that temporary restoration before the patient leaves the office that day. So you can either have a preformed crown that you adapt and shape to the implant with a temporary abutment. But in this situation, when I have the actual tooth, that's what I prefer to use. So what you see on the left is the tooth that has been cut off. And what we do is that we only keep the buccal component of that implant, of the tooth. We make basically an enamel veneer. And then we place that in the patient's mouth, and with the help of some flowable composite, we immobilize it in place, as you can see on the second picture from the left. Once this is done, this is the way that that temporary abutment that you can see right here. This is the enamel veneer that's part of the patient's tooth, and this is the flowable composite. We'll go back to the lab, and now we only have to recreate this emergence profile right in this area. And that's what we are doing in the lab, just with additional flowable composite. And then, of course, we move forward. And once the placement of the implant has been realized, we're going to graft that buccal bone, and we are going to deliver the final restoration, the temporary restoration. Now, the question would be, are you always grafting, that area? And the answer is absolutely yes. You always want to graft that buccal gap between the implant and the remaining socket, because if you look at the anatomy, about 90% of patients have what we call a thin biotype, especially Asian population. And that buccal bone is extremely thin, and after it's covered by also a thin type of soft tissue. So especially that area, we're very prone to recession unless you are actually grafting that area. So the picture you see on the right side, the red and yellow area, describes the amount of bone that you will be losing if you don't graft that socket. Of course, if you have a very thick bone, which is present, however, extremely rarely, only in about 10–11% of our patients, there might be less of that resorption. But again, in 90% of the patient, you actually will need that type of grafting. So we do it with everybody. So again, if we go back to our patient, this is the temporary crown after a number of weeks. So then we're going to proceed with the work on the tooth number 2-1. As you can see here, we're going to remove the crown that is already in place. On 1-1, there is still a temporary crown. And then basically, we're going to fabricate 2 new crowns on both the implant on 1-1 and the tooth on 2-1. Here is a sequence of the radiographs from the tooth being present, to the tooth being extracted and the implant in place, to the implant being placed with a temporary crown on the third pictures from the left, and of course, the final crown on the picture further to the right. So again, here is your restoration. And then one thing that is important is to realize that it is in this temporary restoration, often the screw access hole is very, very close to the incisal margin of your tooth. Now, while that is not a problem in the temporary restoration, the lab is going to have a very hard time having a very, very thin layer of porcelain in that incisal area, which often will really look not right. So we need to re-angle, redesign that, the inclination of the screw channel. And often we use these components that we call them angle screw channels, so angle screw abutment, that allow the engagement of your screw with basically a different angulation of your screwdriver and a different type of the screw. And a large number of the manufacturers, all of them have this type of solution. By doing so now, we are replacing or redirecting that screw channel in the most ideal situation towards the palatal side. Let's look at other cases like this one over here. This is a young man with tooth 1-1 that has been basically fractured, as you can see right here, right at the junction between the coronal third and the middle third. So the tooth is, of course, hopeless. The tooth is extracted, the root is removed, and once again, a temporary crown is made with a temporary abutment so that it can be replaced right at the same time and therefore support the soft tissue of the extraction site. Here again, you start seeing that that site is actually ideal in terms of the molding of the soft tissue. So again, then we can proceed with the final restoration, as you can see right here. Let's look at one more case. And in this case here, you see that there are 3 teeth, actually 4 teeth, but the 3 of them are 1-1, 1-2, and 2-1. And actually, they're all basically composite. You will see in a minute on a radiograph. So they are not great teeth in terms of fabricating tooth-supported crowns. So we extracted all of them, placed the 3 implants, 1 per each tooth. And here you can see the radiograph before the extraction was done. And here you can see the 3 implants placed and the temporary restoration being placed at the same time. These are the temporary restoration being placed at the time of surgery. You can still see a little bleeding in the intrasulcular area. But if you let that area mature, again, this is the soft tissue outline that you can actually achieve, which is actually fairly positive. And this is the final result of these patients. Again, quite pleasing. So, having spoken now at length about soft tissue, there are going to be some situations when that soft tissue management needs to be really enhanced a little bit. So let's discuss a little about soft tissue management. So the soft tissue management can occur before an implant placement or before abutment connection, can occur during the implant placement or during abutment connection, and both of these are good, are potential positive, can I say, strategies, or as a negative strategy, as a strategy to make up for complication, can be done after abutment connection and generally in the management of complications. So we certainly want to avoid the latter. So if you look at choices of soft tissue, the soft tissue can come, of course, from the patient in terms of a gingival graft. What are the positive? Quite predictable. Very simple surgery. However, we generally use that in non-aesthetic area, generally in the posterior area, because the gingival graft will often not blend perfectly in place with existing tissue, and so will be actually not aesthetic. Certainly not as aesthetic as a connective tissue graft, which is the second choice of autogenous soft tissue graft material that can, again, be taken from a number of donor sites, and certainly is quite effective in improving the value of the tissue around our implant, and certainly to a lesser extent, the keratinized mucous extent. Again, it's also a simple surgery, but there is a certain limit in the availability of autogenous material. And then you may have actually an allograft or a xenograft that comes, of course, from a donor side, either of another human or, of course, an animal, which in this case, of course, there is no donor surgery, and the availability is virtually endless, of course. So if you look at, for example, a posterior site, like you can see over here, in a 4-6 area where 4-5 and 4-6 area where 2 implants will be placed, it's not uncommon to see that there is an invagination of the mucogingival junction, and now there is a scarcity of that keratinized tissue that we really want to have surrounding the entire implant. So in this case, again, taking just a gingival graft from the palate, as you can see from the right side already sutured in place, it is the ideal way to go. And then again, once your soft tissue is thickened, it's keratinized in nature, we can progress and certainly place the 2 implants here, like it was done by Dr. Hosny, one of our implant fellows. So we can go from the picture on the left, as you can see here, to the picture on the right, where now the tissue is keratinized, is thick, is voluminous. So we have really confidence that that area will be nicely maintained. You can then place your soft tissue during the implant placement. And again, here you might have a situation like you see here where you can place some allograft. You can stabilize it underneath your healing abutment. You place it underneath your flap, suture everything in place, and basically let that area heal so that you are able to thicken a little bit that tissue once again. Again, similar here with another material, in this case called FibroGuide. It's a little harder to handle, but does work well in this area. Placement of an implant, placement of this very thick, collagen base soft tissue xenograft. And then again, you're closing around that healing abutment. And if you go from the preoperative photos to the postoperative photos, you can clearly see that the result has been achieved in ensuring that the buccal component of the peri-implant tissue is nice and thick, and it is again keratinized. Here, a little joke. This is a patient of mine that have done exactly that type of xenograft, soft tissue xenograft placement. But you might see that this patient had additional requests. And one of the requests in the crowns is that each crown be characterized. Now, what he told me is that he wanted to have that crown on the area 46 with a dollar sign. And you can imagine the face of my laboratory technologist when I asked him to put a dollar sign on that crown. The reason he said that he wanted to have a dollar sign is because he told his grandson that rich people, how do rich people recognize each other? And he told me that they recognize each other because they have dollar signs on their teeth. And of course, the child believed the grandfather, and the grandfather had to deliver on a crown with a dollar sign. So again, these are sometimes some of the challenges we have sometimes in our practice. So remember, we mentioned before that soft tissues are generally about 2 millimeters thick. So we need to have basically 4 millimeters for the biologic width. So all of these strategies of thickening the tissue really come from a couple of studies done by a Lithuanian author, Thomas Linkevicius, which has done a fair amount of work showing that if your tissue is thin, you might expect more crestal bone loss. But if your tissue is thick, or you make it thick with a graft, that bone loss is actually minimized. So again, you need to pay attention to the soft tissue thickness. In this case, it was not done. And you notice that there is a little bit of crestal bone loss, and towards the distal buccal side, that tissue is really not present at all. You have an exposure of the abutment and of the implant. So again, here in the posterior area, this lends extremely well to the placement of a free gingival graft. You put it in place, take it on the palate, suture it with interrupted suture and some horizontal mattress suture to make sure that it's in contact with the recipient bed. And if you let it heal nicely, you pass from the left picture pre-op to the post-op on the right side. Now you see that there is tissue in that area that allows the patient to maintain that area nice and clean. Remember, it's not a matter of aesthetics in this area. It is a matter of health and peri-implant health, because we know that if we do not have keratinized tissue, patients have a greater tendency of bleeding or probing, a harder time brushing, and certainly greater tenderness upon brushing. So the presence of a cuff of keratinized tissue is quite important. Now, if you look, however, at the anterior area, remember we saw this case where there was an implant on area 1-1. And generally we say that, if we do this, we place an implant immediately and we maintain the soft tissue, that things are predictable. But now, what do we mean by predictable? So if you place an immediate implant, more often than not, you need to anticipate a little bit of buccal recession. So if you look at the picture on the left side and you compare to the right side, it's the same patient, but tooth 1-1 has been replaced with an implant. So you can see that, again, we're looking at microscopic detail that often the patients might not even be able to realize, but sometimes they do. So you have a little bit of a recession again around tooth 1-1. So we need to be well versed in recognizing that and perhaps thinking if a soft tissue graft in this area can improve the outcome of those soft tissue. And the answer is often it can. So let's look at this case together. If you notice, that lateral tooth will be extracted, but you already have a problem in the aesthetics of that soft tissue, both from a buccal standpoint, and if you look at that tooth from a coronal, from an occlusal standpoint, you already see that there is a concavity of that soft tissue. So that concavity, the loss of soft tissue, will actually be made only worse by the extraction of the tooth. So yes, we can place that implant, as you can see right here, the implant has been placed, but at the same time, we need to over-augment that area so that we're not going to have a concavity. So it's a connective tissue graft will lend itself extremely well to do this, and it can be taken from a number of areas. Generally, the palate is one of the most common donor sites, but if we have availability of tissue towards the tuberosity does actually quite well as well. We just take a chunk of tissue and then we cut it in half to basically make it thinner and longer. And we actually just finished now a project, actually a clinical study in these areas, comparing connective tissue graft from the tuberosity versus the palate. And we've actually seen that there is really no difference. So again, depending on the availability of those sites, you can select really where you like to take it. This study will likely come out in the Journal of Oral Implantology, and the main author will be one of our periodontist staff, Dr. Eliana Cozzalidi. So again, if you look at this case now, we went from the picture on the left, where again, we had a significant aesthetic problem, to the picture on the right, where coupling that soft tissue grafting with the ideal shape of the tooth and its emergence profile, we're able to really recreate ideal aesthetic situation. Again, other cases, tooth number 1, 2, where you can see, of course, that there is a cavity, there is a significant problem on this tooth that will have to be extracted. But at the same time, what you see both on the reformatted CT and on the cross section is that there is also a periapical radiolucency right here that you can picture also in this area right there. So we know that we have a fenestration in the buccal bone in that area. So again, in this situation, you do not want to lay a flap. You want to remove the root as atraumatically as possible. You want to place your implant after, of course, you have removed and cleaned and debrided the periapical area. But then you know that you have that fenestration. So you also need to go with a submarginal incision at the level of that fenestration so that you can actually fully clean it up. And then, of course, place some bone graft in that area, which, again, is extremely easy. Doing this approach without laying a flap, it helps preserve the integrity of the gingival margin. So now you're letting the area mature. This is the area, of course, with the temporary crown. But when you start looking at the difference between right and left, and again, we're looking at microscopic differences, you see already that on the area number 1, 2, the soft tissue has a little bit of a concavity. It doesn't have that root prominence as it has on the area 2, 2. So again, in this case, we took a little piece of tissue. It's basically a free gingival graft, but then we remove the epithelium, we transform it into a purely connective tissue graft, and then we are going to slide the soft tissue. It's, again, relatively easy with engaging it with a suture. Basically come into we make a little pouch in this area, and then we come with a suture resorbable through this area here, engage the soft tissue graft, and basically come out again with the needle so that we can use the suture to drag this connective tissue graft right underneath this little pouch that we made. And you can see right here, this is the connective tissue graft barely peeking through the gingival margin. But if you then let that area heal, you can see that that area looks better and better, every day. So this becomes, again, a nice, nice result. Now, this, of course, is not it's not an immediate site, but I'd like to show it to you. It's one of the last cases I want to show you before we discuss, perhaps with some questions. This is a case where we have a significant alteration of tooth 1, 2, and 1, 3, with a fair amount of loss of not only soft tissue, but also hard tissue. Again, in this case, and we will perhaps have a chance to touch base another time, we know that we have to rebuild that area after that 1, 2 tooth comes out. So we have used an approach. We have some tenting screws, a resorbable collagen barrier, and then a combination of autogenous and xenograft. And the idea, of course, is that we want to rebuild as much as possible the hard tissue component of that area. But then again, as we have done that, we've been successful, we need to start thinking about the soft tissue component. So what we did in this specific case, we actually did a particular incision where we leave a piece of that connective tissue right here. So this is we call it a full split incision, in such a way that we can keep this soft tissue right here, then have here a hard tissue, a full thickness flap, and then further down another split in such a way that we can advance the flap. Now, what is the reason of having this platform of soft tissue? Well, we're going to place our implant, as you can see here, and we're going to place one implant in this case to support both teeth. But we want to have this platform of soft tissue here so that we can try, to the extent possible, to immobilize then a block of connective tissue to try to rebuild some of this papilla here. Now, we know already that's not going to be perfect, but at least we're going to try. So here, temporary restoration, well, we know that there is absolutely no way that we can make a papilla like on this side here, on the treatment side. If you let that area mature and you follow up with the restoration, you start seeing that now the idea is that this part has proliferated at least a little bit. And the longer you wait, the more in general, within limits, of course, this area will look better and better. So this is the final result, both from a radiographic as well as from a palatal standpoint. And I'm probably going to actually stop here because this is going to an area of further complication. And perhaps I'm going to leave that for another time. So I'm going to stop sharing my screen, and I'm going to leave about 10 minutes for questions in case there are from all of you. So let me stop sharing this, and I'm going to go back to our Zoom component here.
Okay. Thank you so much, Dr. Ercoli. We do have a question here from James. It says, why is it very important to do a digital impression at the placement stage? It is important from a matter of efficiency. You don't have to do it. If you like to do it after, that's perfectly fine. Your result will be exactly the same. But if you're working in a practice and you place that implant and you're going to make the crown yourself, taking an impression right at the same time will basically eliminate the need for an additional appointment. So it is a matter of efficiency in the practice. Okay. So are there times where you would not do an immediate? I mean, I know patient wants is in front. Are there occasions where you say, you know what, I don't think we can go ahead?
Yes. So in the posterior area, with a time where you can't stabilize the implant, no matter how you do it, you tried, but perhaps the implant stability is not ideal. You need to abort. You need to remove the implant, even if you try to stabilize it, and you need to graft the socket, go back about 3-4 months later and place the implant. In the anterior side is not only when the implant is not stable, but when also you are extracting the tooth, and now there is a fenestration, there is a dehiscence of the buccal bone that you can't really rebuild.
Okay.
So in those areas, you need to stage it. You need to graft the area. You need to come back, place the implants, and perhaps optimize the soft tissue.
Okay. What if an instance where you are not able, the implant you are placing does not get to the apical portion of the tooth that was removed, but it was stable? What would one do in that case?
So if it is a posterior area,
that is absolutely okay, because we have a lingual and a buccal component of the bone which is thick, so allows us the implants to engage those areas without fearing, like you will have in the anterior, that the engagement of the implant will lead to the resorption of that bone and therefore a recession. So in the posterior side, it is perfectly fine. But in the anterior side, you do not want to engage the buccal bone. You want to keep it towards the palatal.
Okay, James, James, I've allowed you. You're able to unmute your mic. I know you have another question. James, if you can hear me, I've given you permission to speak. There's a question you had a follow-up question.
Yes, thank you very much. Thank you for the lecture. I'm still concerned about this initial impression, which is being done at the surgical stage. I'm concerned because of the way we know about the healing and what happens to the tissues at the end. We might get a totally different tissue architecture at the restorative stage. So I'm wondering what will really be the value of this initial digital impression at what's the contribution of it at the restorative stage? Thank you.
Well, thanks for your question. So, as I mentioned, it's a matter of efficiency. So you're absolutely right that the soft tissue. Let's say you take the tooth out, you've taken out a molar. Your healing abutment, no matter how wide it is or how different it is, does not have the emergence profile, does not ensure an emergence profile that's the same as what you have in the tooth, unless you make a custom one. So realistically, the soft tissue architecture in the premolar or molar area can actually be recreated by the final restoration. Remember when I showed you at the beginning that you make small incisions towards the mesial and the distal papilla. So what you don't have to worry about the soft tissue architecture. In fact, you tell the lab, they often will ask you when they are new to this technique, how do I design? What do I do with that tissue? And in a digital environment, you can segment, you can basically remove the tissue digitally. If you're taking an analog impression, you can do it on your cast. But effectively, you ignore the shape of the tissue, the profile the soft tissue that you have as you're taking that impression. You design your crown purely with a natural emergence profile like you will have from any anatomy textbook. And then you deliver with those two incisions on the mesial and distal papilla if needed at the time of delivery. Now, every practice is different, but in a practice like we have, the overhead costs, meaning the cost for each hour of our practice operating is roughly $750. It's a lot. So if you can decrease the time that you need for that restoration while you're achieving the same result, as I show you with some of those papers, it is an advantage. But you don't have to do it. If you like to do it in stages, that is also perfectly fine.
All right. There's one question here about how difficult are manual impressions compared to digital ones during that immediate implant sitting?
It's actually a great question. I was glad that somebody asked it. So we have been taking impressions at the time of surgery for probably like 15 years, okay? The issue becomes twofold. If you're taking an analog impression with your normal impression material, there are two potential problems. One is the fact that you have an open socket, and if you're not careful, some of that impression material might actually go further down into the socket and potentially compromise your surface of the implant. If, of course, you're taking a digital impression, you don't have to worry about that because there is no material going there. The other advantage of a digital impression at that stage is the fact that effectively you don't touch the implant. So let's say you're taking an impression with impression material. Almost regardless if you're using an open tray or a closed tray, once you remove the impression, that implant will be subject to some tension, to some forces. And at times in this situation, when you have an immediate implant, your primary stability isn't exactly great, okay? So you don't want to pull too much on the implant to avoid that the implant comes with impression. So doing a digital impression where you actually don't do any pulling, you're just scanning the position of the implant is a further advantage of using a digital approach to do this.
Okay. Doctor, there's someone who was Dr. Let me allow him speak here. Dr. Carlo, he was with you sometime back in the day. He wanted you to throw some light on the SAC classification.
Sure. So the SAC classification is has been designed actually for a number of years by the International Team for Implantology. And as I said, I'm a fellow. I'm actually now the chair of the East part of the United States for the ITI. SAC stands for straightforward, advanced, and complex. So a straightforward case, if you look at that classification, is very helpful. And again, you might use another one that has achieved the same result. But a straightforward case is one in which soft tissue, hard tissue, from a medical standpoint, from a local factor standpoint, everything is ideal. Almost anybody with, even little level of experience might, proceed with those cases. And then you have, further, complications. So an advanced case where perhaps the spacing or, the site needs some little grafting or may need some, changes in the interproximal, area. So you're basically increasing the potential complication. And as you increase the potential complication, you need to be more careful as far as, do you have the knowledge and skill to do those complex cases or those advanced cases? Or do you need to look for some guidance from some individual that might have, more experience than you have? And at the end, it's always like, the rule is treat everybody like you treat yourself or you treat your mother, or, and so that's the ethics that I think we all need to apply.
All right. I know your time is fast spent here, but one of the participants all the way from Nigeria just sent me this photograph. It says the central incisor and the lateral are both implants. And I wanted you to, if you could comment on this case, what would you do? I mean, this is all we have. There are no radiographs for right now. Sure.
Well, of course, if those two teeth are implants, you're having a challenging situation. Not only because, I will guess that the position of the implants and the bone availability is further, apical, but also because it appears to me that you have some recession on the tooth 2-3 as well as on 1-1. So that tells me that when you have a recession, generally you have a thin buccal bone, you have a challenging periodontal situation that might need a composite approach to be dealt with. I think at the minimum, those situations, you have two choices. If that patient, has a very high smile line, then you might think about attempting some grafting, some ridge augmentation in that area. But you need to realize that in those situations, no matter how good you are, 9 out of 10 cases or 8 out of 10 cases will not come out exactly as you were at the beginning. So you will need perhaps to have, especially in the papillary area between 2-1 and 2-2, some form of pink porcelain. So then the question is, if you use some pink porcelain, let's say that the patient has a low smile line, does not show that area, and perhaps he or she is just unhappy on seeing those gaps, perhaps those two implants that you have, or perhaps a replacement of those two implants, can actually incorporate some pink porcelain to rebuild the entire area of the soft tissue, which is missing. And then, of course, have, two good-looking crown as well. So there are certain points in which you can increase, the soft tissue, but there are situations in which you need to pick your battles. And here again, when I look at this mouth, I see, recessions and abfraction in a number of areas, including in the mandible. So that tells me that that individual is probably not the easiest individual from a thickness of the soft tissue standpoint and the ability to recreate bone and soft tissue phenotype.
Okay. All right. Thank you. Thank you so much. Thank you so much for this wonderful. I mean, we're going to go back. So we do have folks from Kenya, Nigeria, Zimbabwe, and Tanzania. It's been. Thank you so much. I really appreciate this. So I noticed that you do have next. I know your slides are pretty long. You usually give 2-3 hour lectures. Do you have a lecture on complications?
I do have complicated, a lecture on full arch prosthesis, if you like, overdentures. I can speak for days.
I know. I mean, if you are, whatever you can give to us, we'll take. We do have this lecture series for the next 8 weeks, every Sunday. So whoever is able to, whenever your schedule allows, I will talk to you offline and see.
Sounds good.
All right. Greetings to the family. Thank you so much.
My pleasure. Thank you. Thank you so much to all of you. Bye-bye.
Bye-bye. All right, thank you guys for coming. It's been so this particular lecture I need to is going to be available on YouTube. It's on YouTube right now as we speak. I guess that's the way I'll be doing it going forward. So I don't have